Warning, this program will discuss adult themes. Viewer discretion is advised.
Thank you. Good afternoon. It's an honor and a pleasure to have Dr. Tim Flanagan here as a guest at our conference, and it's a special honor to have him speak to us. We're just talking about the introduction, and Dr. Flanagan told me to keep it short. I've been a fan of Dr. Flanagan's. I've read his articles over the years and have been very impressed by them, and he's had a strong influence on me and upon many of us, I'm sure. But I was told to keep it short. I asked Angelo, I said, well, to keep it short, what should I talk about? And Angelo said, well, about 2 minutes. But anyway, on with the introduction here. Dr. Flanagan is the Director of Infectious Diseases at Brown University Medical School, where he holds the title of Dean's Professor of Medical Science. He is also an active staff physician at the Miriam Hospital and at the Rhode Island Hospital, and he is the Director of Infectious Diseases at both of those institutions as well. Dr. Flanagan completed his internal medical residency at the University of Pennsylvania in Philadelphia and his fellowship in infectious diseases at the Case Western Reserve University in Cleveland, Ohio. In addition to his many faculty and committee appointments, Dr. Flanagan is studying for the permanent diaconate program. He's studying in that program in the Diocese of Providence, Rhode Island. Dr. Flanagan, in addition to his faculty appointments and his committee appointments, he's written a number of articles, over 200, on the subject of infectious diseases, focusing on HIV and other sexually transmitted diseases. Some of his special areas of interest have to do with communities that are particularly affected by this disease, especially people who have served terms in prison and individuals who have suffered from substance use of one kind or another. There are many things I'd like to say, but I will introduce Dr. Flanagan. It's a pleasure to have him here. Thank you. On behalf of Courage and Encourage, we'll welcome Dr. Timothy Flanagan.
Thanks, Dr. Jim. So I think you're going to flick the, we'll get my PowerPoints going, because if I have to speak without PowerPoints, that's really tough. So I'm a practicing physician. I'm at Brown Medical School. I've been taking care of patients for 25 years. I have 2 half-days at clinic with our hospital at the Miriam, and then I do a half a day at the Adult Correctional Institute. I started that 20 years ago, and I still do it today because the need is great, and it's so interesting, and it's frankly a great place to see some of the people that we care for. I will tend to go through my slides quite quickly. You're welcome to interrupt me and say, hold on, I have a question, but I hope we'll also have some time at the end for lots of discussion. This is a big area, and it's fascinating and gripping and important. Now, you notice on my slide it says Professor of Medicine. I was going through my slides last night, and I didn't have the candlelight, so I was using my phone and computer to do it there, and I had to cross off Chief of Infectious Diseases, because 10 days ago my replacement came, because I'm staying as an infectious disease doctor and staying as an HIV doctor, but my ordination is scheduled, God willing, in February as a deacon, and that means I will be doing that 20, 30, 40% of the time, who knows, whatever God has in store, and so it wasn't right to stay on as chief of the division. Thanks. To be honest, it took me about 2 or 3 years to be able to say, God willing, I'm going to be ordained, because I found it quite scary. Okay. I'm going to start out with the series of 5 slides. This is the United States, 1983. Each yellow dot is 30 cases of AIDS, and this map is from the Centers for Disease Control. As you can see, there are just a few yellow dots in New York, Florida, Texas, California, Chicago. 1985, just a few more. 1989, there have been 100,000 cases reported. 1995, and 1997. 1997, there were about 600,000 cases. It's now estimated there are about 1.2 million people with HIV in the United States. There are around 40 million people worldwide. How did this epidemic grow so quickly and at this proportion? Particularly early on, when there was both very little known about it, but very little that was said about it. And HIV grows within an environment of denial. And the stigma and the fear really promotes that denial. There's also another biological fact, and that is HIV as a virus, once you're infected, you're asymptomatic for years and years and years, but can spread it during that time, largely sexually, but it's a long time till you get ill. Now, that's a very different infection than, say, influenza. If I came here with influenza and I shook Dr. Jim's hand yesterday and he went around and shook a bunch of other people and I was up here and I didn't want to cancel my talk, so I was sneezing and a bit sick, I can tell you, within 5 days, about a third of you would have influenza. And you'd go, oh, that Flanagan. Maybe he gave a good talk, but he's really a jerk because he gave us all influenza. HIV, there's this long latency period, and most people that have it during that time don't know they're infected unless they get tested. So HIV spreads within an environment of denial, and this asymptomatic latency period allows it to do that. Now, this is the United States. This is a slide of Africa, and we tend to think of Africa as being overwhelmed by HIV. But that's not quite the case. Northern Africa has lower rates of HIV than the United States. Western Africa has modest levels. Eastern Africa, Kenya, Uganda has quite high rates. And Southern Africa, the rates are hyper-endemic. And in different countries, whether it's Zimbabwe or Botswana or different parts of South Africa, the rates are 15, 20, and 25% of individuals between the ages of 18 and 45. So this heterogeneity is very important, and it's important for us to understand what's going on with the scourge of HIV and this terrible epidemic. Not only that, but the time course of these epidemics is very different. This slide shows the general prevalence rates in adults between 1986 and 2004. And the very bottom of the slide is cut off, so I may just explain that as it goes. And you can see that in the green line is Uganda and in Kampala. And there, back in 1986, 15% of pregnant women were HIV infected. It went up to 28%, but then it decreased dramatically and it stayed down. So under 5% of pregnant women are infected today. That is remarkable. So there's been a huge decrease in the HIV epidemic there. In Dakar, Senegal, West Africa, it's low and stayed low, whereas in Swaziland, which is part of southern Africa, the epidemic took place much later, but it escalated, and they are still suffering horribly from an incredibly awful burden. Okay, so there have been declining rates of HIV in different parts of the world, and this is a little bit of a headline. So the national HIV prevalence rates have declined in Uganda, Kenya, and Zimbabwe. In urban parts of other areas in Africa, there have been declining rates. And interestingly enough, in the Caribbean, particularly Haiti, the rates have dropped dramatically from 6% early on to under 2%. So that's good news. Now, this is the story of Kampala, which is the capital in Uganda, which early on, 1985, was faced with this awful epidemic. 10% of pregnant women were positive. It's hard to understand the suffering and the scope of this illness when 10% of pregnant women are HIV infected. And in those days, there was no good treatment at all, no treatment at all, and no good treatment, and all those individuals virtually have died. So the rate went up to 30%, but then look at this dramatic decline year by year. Just amazing. How did this happen? Well, so the entire country mobilized, and this was from the president to the religious leaders. Uganda is Roman Catholic and Anglican, to celebrities, to business leaders. So national leadership can never be underestimated, and human capital is so important here. One of the famous rock stars in Uganda became HIV infected. He spent 3 years going around the country talking about the fact that he was HIV infected and what this meant. The rate of infection fell dramatically. Uganda actually created its own language, which was sensitive to its own culture and community. Really, really important point. And it's a very agrarian culture. They talked about zero grazing, and they were very clear that abstinence is of utmost importance. You know, early age of sexual debut, that's sort of a technical term. Traditional term, abstinence, is, early age of sexual debut is the opposite of abstinence, obviously, but it's disastrous in terms of transmission of HIV. Multiple partnerships spreads the infection very readily. And if somebody's going to go out to a brothel, have casual sex, not using a condom, will spread HIV as well. So they integrated this together. Now this is a little different story, but there's very good behavioral data which I'm going to go through. This is a story from Kenya. This is later, 1990. The epidemic started to take off after the epidemic took off in Uganda. It took a while for the country to wake up and say, we really have a problem here. Early on, largely because Kenya relied on the tourist trade. So denial was the name of the game. Don't mention it to anybody. It might impact our tourism. Finally, they realized what a disaster this was, and these again are rates in pregnant women nationwide, 5% up to 13%. But then a very rapid decline in the course of about 6 years, and that's a more than a 50% decline. Wow, how did this happen? So this is data from the Kenya National Behavioral Health Survey, and it's looking at the whole issue of what we've coined ABC, abstinence, be faithful, condom use. And the question is, does this work? Can this happen? So what you see on the far side, I guess your left, starting out is young men and young women who are never married, 15 to 24-year-olds, who have had sex in the past year. And you see very substantial declines between 1998 and 2003, a 5-year period in behavior. People said, well, this can't happen, and the answer is it does happen. As I'll talk about a little later, multiple partnerships, and even to refine a little more, concurrency. Concurrency means multiple partners around the same time. So let's say you're a truck driver and your route goes from Mombasa on Kenya all the way to the other side of Africa, and you have a different girlfriend in every town. Well, if you get HIV or you get a sexually transmitted disease, you're at very high risk of transmitting that to each other person at the same time because you've got multiple sexual partners within the same period of time. That allows ping-ponging of infection back and forth. And you can see within a 5-year period a 50% decrease in multiple partners among men and women. Just phenomenal. Really incredible. And this is important because it demonstrates that behavioral change can occur at a community-wide level. You also see very slight increases in condom use, not dramatic. And this is why some very important work really is looked at both abstinence and decrease in multiple partnerships as key from a community level in terms of decreasing the epidemic. Now people still say, hold on, you can impact women, but impacting behavioral change in men is, forget it. You're never going to do it. It ain't going to happen. So this breaks down that data a little more. And you can't see on the bottom here, but the first 2 bars are young 15 to 19-year-old men. The second 3 bars, the red, blue, and gray, are 20 to 24-year-olds. And then you go to 25 to 29-year-olds, 30 to 39, and 40 to 49-year-olds. And what you're looking at is the proportion of men having more than one partner in the past 6 months. And what you see is incredible declines, and now this is a 10-year period between 1993 and 2003, with the biggest declines being between 1998 and 2003. And how did this happen? It happened because people fundamentally want to be healthy, want to have healthy children, and if we're able to teach and let people know the risks and the dangers, particularly related to multiple partnerships, their effective behavioral change can occur. And this is what happened here. And I showed you the more than 50% decline in the generalized epidemic in Kenya. So really important. Okay, so the top line here is the rates in Uganda going down between 1987 and 2000, but the dotted line is the skyrocketing epidemic in South Africa, which occurred around in the same period. And people say, well, I mean, this shows that while the epidemic was declining in Uganda, it was taken off there. How did that happen? And I'm going to go through 4 different aspects of it. The first is acute HIV infection and concurrent sexual partnerships drive the high rates of HIV. And I'm going to show a little bit of biology now, and this is important because this is also a key driver of the HIV epidemic in men having sex with men and gay and bisexual and transgender men in the United States. So this slide shows the level of virus in a person who's HIV infected. And it's a logarithmic scale. On your left is the logarithmic scale. So where it says 2, that's 100 copies of virus in a milliliter of blood. 3 is 1,000 copies of virus. 4 is 10,000. And 5 is 100,000 copies of virus in 1 milliliter of blood. So this shows that when a person gets HIV infected in the first 3 weeks, the virus disseminates widely throughout the entire body. It's in the blood, it's in all the lymph nodes. Sometimes folks get a rash, a little bit of a headache, but by and large, people aren't too sick. About 10–15% of people might go see a doctor, and the doctor will usually say, oh, don't worry, you probably just have a viral infection, it'll probably get better, and the symptoms do go away. It's a little scary. But during that time, that early period, the virus replicates at very high levels. We've seen patients that have 5 million copies of HIV per milliliter of blood. That means in their whole body, they have billions of copies. And when you have virus in the blood, you also have virus in the semen among men and in cervical fluid among women in the genital tract. So it's disseminated. And your risk of transmission during that early period is really high. So if you have multiple partners around the same time period and you get HIV infection from one of them, as the virus disseminates, you're highly infectious and at high risk of spreading it to other people and the virus going back and forth and back and forth. Then the immune system kicks in. Our immune system is extraordinary and it brings the level of virus down. And the level of virus is down then for many, many years. Some people are asymptomatic for 5 years, some people are asymptomatic for 10 years. Some people are asymptomatic for 25 years. We've taken care of patients that have no symptoms and their immune system controls the infection very well for 15, 20 years without any treatment. We conversely have other patients where the virus it spreads very replicates at a very high rate. They tend to get sick quite early, and we have to start medications very quickly, and then they do well with medications, but without medications, they would be sick with infections and probably die in just a couple of years. Before therapy, some of them died very rapidly. And then over time, the level of virus can go up. So multiple partners during this acute infection period allows rapid spread. So why are the rates so high in Southern Africa? One is the acute infection and concurrent sexual partnerships. Second is low circumcision rates. There have been a number of studies showing that circumcision decreases risk of transmission of HIV by a lot, about 70%. Third is high rates of sexually transmitted diseases. This can include genital herpes, it can include syphilis, it can include gonorrhea or chlamydia. And the rates can be very high in these communities, same thing, because of multiple partnerships. And we've seen, unfortunately, as we'll talk about later, there's been a big upsurgence of syphilis in gay and bisexual communities in this country. We've had a 3-fold increase in Rhode Island, and Massachusetts the same, of which 80% is in men who have sex with men. And then last, in Southern Africa, no community mobilization, meaning that there was real confusion about this. And I don't know if you recall that the president of South Africa even said they weren't sure that AIDS was really caused by HIV. This is really imported from the West, and it's not really their problem. So a real lack of leadership to face up to the reality of how terrible this infection is. Some groups have tried very hard to do this. In Botswana, the bishops came out and said all couples should get tested for HIV before marriage. In America, people said, oh, you can't do that. I say, well, hold on. What makes sense in their community? And with rates that were so high and with so much heterosexual transmission, that was a very reasonable response. So some groups did show that leadership and others did not. So we've also learned that HIV testing and treatment are really key for prevention. So in the past, there were folks that would focus on HIV prevention and other folks that would focus on HIV treatment. We now realize that that dichotomy really is not helpful and is not productive. First of all, testing is key. Our tests for HIV are extraordinarily good. It's now recommended that every single pregnant woman be tested in this country, and all adults between the ages of 18 and 64 be tested at least once. Individuals at higher risk be tested again. Why? Because our treatments are so good. And this absolutely does make sense. Without testing, you really can't do, prevention is very hard. If you're really worried about somebody getting HIV, you should be testing. And without treatment, you certainly can't do testing. Therefore, our whole paradigm about HIV testing has changed to make it routine. The other thing that's happened is our treatment. And this is a complicated slide that I'm not going to pass out a test on. But the thing in the box is a cell. And there are different parts of the life cycle. But all of the names listed below in the two yellow boxes and the red boxes are different HIV treatments. And we now have 25 different approved medications. The one we most commonly use is 3 medications in one pill called a tripla, which we have now been treating patients with for more than a decade, and many of our patients have consistent suppression of HIV viral load, so that even though some of them had very high levels of virus, on these combination medications, we bring the level of virus down so it's non-detectable. Now, I'm going to slip that. These meds work incredibly well. These are slides from Africa, and this has been dubbed the Lazarus effect, but I've seen this in my own patients, where they literally, their health has dramatically improved, so it's hard to believe. When we bring that viral load down to non-detectable, we really stop the virus from replicating. We tell our patients that the virus is in remission, and I tell my patients that if they are willing to engage in their health and take responsibility for their health, they can take out a 40-year mortgage on a house, because this infection is totally controllable. It is not curable. So the success of our treatments is extraordinary. Again, it's usually, I don't want to connect to the Wi-Fi right now. Okay. So it's 3 medications, usually once or twice a day. Often it's combined in just a few pills. It used to be a huge number of pills. Interestingly enough, the Indian generic manufacturing firms have developed these meds, and they can do it at very low cost. And we can totally suppress the virus. Here in this country, the cost of care for a year is between $5,000 and $10,000. It's down to under $100 in different parts of the world. So we really believe that treatment can be effective for a lifetime with total restoration of health. This is amazing. And I used to do a lot of hospice work. I did a lot of home visits, taking care of patients that were dying. And our patients do die. Unhappily, one of my patients just went home with very bad lung cancer, but they're by and large not dying with HIV and AIDS. They're dying with it, not because of it. Some folks still won't take their medications, and so then that's not the case. Now, treatment is more than medications. It's also support, and that's both medical and social and familial. This is interesting. This is a slide in Uganda, which is a group of women beginning antiretroviral therapy, and they're praying. And this makes so much sense. And it's unfortunate that in the U.S., in our context, everyone's uncomfortable about religious faith, and unfortunately, the medical profession hasn't been taught that it is appropriate to bring up faith and to share your faith. It can be done in an absolutely respectful way, respecting the dignity and choice of the person. We tend not to do it. And other cultures have shown us, well, hold on, that's not good. You can do this. And this is a group of women doing this in Uganda. This is a slide from St. Mary's Mission Hospital. in Nairobi, where the epidemic is so widespread. Because I showed you that slide where pregnant women, 13% were HIV infected, and that was back in the mid-90s. Well, and mid and late 90s, those are the patients that are sick, and many of them dying today. And what St. Mary's Hospital said is, hold on, we can provide HIV testing. And we're going to test all pregnant women as well as adults, and we're going to provide care for both adults, regular adults, and pregnant women. Interestingly enough, 80% of the women agreed to HIV testing, and they have an incredible program to prevent maternal-to-child transmission. And they're doing it in the Kibera slums. And I would say that if you can do this in the Kibera slums, you can do it anywhere. It's most remarkable. We're also finding that HIV treatment is a form of prevention. Among men on treatment, there is a marked decrease in unprotected sex. Using these medications decreases the level of virus throughout the body, so that decreases transmission. And the CDC estimated there's a 90% reduction in transmission among Ugandan men in treatment. There's a new study that was big news, and it just came out this year. There are 3 new breakthroughs I'll talk about. This is the first. This goes by the name HPTN-052, and it talks about prevention of HIV through treatment. They took individuals who were relatively healthy. That means their immune system was quite strong, and they had higher CD4 counts. That was over 350. So these are folks that at that time normally would not get treatment. And half of them, they said, we'll just follow you. And the other half, they said, we'll begin you on antiretroviral therapy, on our medications. All of these folks were in couples where the one person was HIV positive and the other person was HIV negative. So they followed these couples over time. And then when the folks with the higher CD4 counts needed medications, they got it. They were all counseled about safer sex. And what they found was there was a 96% reduction in the spread of HIV from the HIV positive person to the HIV negative person when the HIV positive person was on treatment. So we believe that treatment now, not only does it lower viral load, it improves health of the individual, but it could dramatically decrease transmission of the virus. Now there are 2 other new items that came out. One is the FDA just approved a rapid test for HIV that can be done at home. And this is new. We've been doing these rapid tests in our office for a long time, but now approved at home. The second is they approved a common medication which we use for HIV treatment called Truvada, which is tenofovir and FTC, to be used as pre-exposure prophylaxis. That meant, hey, if somebody says, I'm going to go out and have a lot of high-risk sex with a lot of people, if I take this medication, will that decrease the chance that I'm going to get HIV? And the answer is yes, decrease it by 44%. Frankly, that's not very good, but it did decrease by 44%. The FDA approved it. We don't know how this information will be utilized. We're still not sure, and we're still trying to think that through. Now, what's happened in the U.S.? I told you a little bit about Africa. What's happened in the U.S.? In the U.S., we've had incredible declines of HIV among injection drug users. Who would have thought? Someone said, whoa, whoa, whoa. If you're using heroin or cocaine, there's no way you can decrease HIV. And the answer is, actually, that's not true. Turns out that with needles being available through going into a pharmacy and just buying them, not needing a prescription, that folks, the assumption is, well, if you're an injection drug user, you just want to kill yourself. Most injection drug users don't want to kill yourself. Most injection drug users are people. And they are also created in the image of God. They're just caught in the slavery of addiction. And if you say, wait a second, you don't want to get HIV or hepatitis C, they'll agree. And if they can easily purchase a needle, then they won't, and then the rates went down very dramatically. A big surprise. There's also been a decrease among women. But unfortunately, infections in this country have continued largely unabated among men. And the epidemic in gay and bisexual men has continued largely unabated, even though all the different prevention modalities we've talked about. In addition, syphilis and other STDs have continued at very high rates. What's going on? Again, it's concurrency. It's the same biology. That concurrency and STDs greatly facilitate the spread of this HIV. The other thing that's happened is the internet. The internet, you can go on your iPhone. You can go, there's a site, there are tons of sites. One of them, Grindr, will show you a picture of other guys and where they are. Your phone has a GPS. And if you want to meet somebody quickly, around the corner and have a quick hookup, it's totally feasible. And not only that, but people are making lots of money on this because of these internet providers. You sign up, you pay money, you put your picture online, and it's a big bucks industry. So the internet and the sexual industry is fueling multiple partners around the same time, which is concurrency, and that's leading to spread of HIV. It's not an issue of education as well. We've now seen plenty of new infections in college students that know a lot, but they're coming out, they're experimenting, and when that's happening, they're having multiple partnerships, largely through the internet. It's not that they're all going to a hotel room, they're not all going to a college room and having an orgy. They're all meeting other people on the internet in the community, having unprotected sex and getting HIV. So unfortunately, the HIV epidemic has continued largely unabated. It's also fueled by drugs, methamphetamines, alcohol, and cocaine, and these go together. Now, what has impeded a lot of our ability to, both in terms of prevention, testing, and treatment, is still stigma. And stigma is real. Much less so in this country. But many communities in this country, it's the same, and many parts of the world, where HIV is still the leprosy of our age. So I remember meeting somebody in South Africa, and I said, "Why don't you get tested?" He said, "As soon as I get tested, I begin to die. And I know my family, my friends, I will have no one, and I will be alone in the world, totally alone. So I cannot do that." How do we approach it? We approach it really through love and acceptance, and the best example is all of our heroes, Mother Teresa. And she's the one who said, "We can't do great things on this earth, only small things, but with great love." So stigma really fuels the abandonment, the lack of testing and treatment, and continued spread of this epidemic, and has been a huge impediment. This is John Paul II in San Francisco. He was in the cathedral there. There were a group of individuals with HIV, including this child, and you can see he has a couple of handlers there. There's this one guy who looks very unhappy. He must have been sort of pseudo-Secret Service. And John Paul II just went over and scooped up one of the kids and hugged him. And this was headline news with a picture everywhere in the country because he hugged this child. And I can tell you, still when I see a new patient, it's very important for me when I listen to their chest to put my hand on their shoulder. When I'm examining them, their shirt's off, I'm listening to their lungs, I put my hand on their shoulder and their skin because I want them to know I'm happy, I'm happy to touch you. And if you have HIV, you still think, I'm dirty. Is this person going to touch me? So the importance of being able to embrace someone both physically and emotionally is so key. Now, most of what I've said here, everybody agrees with. It's pretty standard. But there is a significant conflict with different approaches. Example is a drop-in center where you can get a hot shower. How can you talk about the dignity of a person if somebody's living on the street and can't get a hot shower? How about a cup of coffee? How about a washing machine where they can get clean clothes? And it doesn't mean you're not going to address the HIV, but you do it within the context of helping the person and recognizing the sexual exploitation, the trafficking, and the drug use, and trying to be there for that person. As opposed to, this isn't a boy, this is a sex worker, that transactional sex, you wanted to desensitize the individual, to decrease the barrier for condom use, do serial testing, decriminalize sex work, very, very radically different approaches. And I believe strongly we have to have a person-centered approach. And this is a obelisk in Argentina. But the bottom line is that the condom solution is not person-centered. It's a risk-centered approach, and fundamentally, therefore, is not authentic prevention and is not effective in the long term. We need a person-centered approach. Mother Teresa's philosophy was we are all broken, we are all in need of healing, we are all in need of love. And God asks us to step forward and with our hands show his love to others. And this is a crucifix from one of their chapels, and as many of you know, in all of their chapels they have a crucifix with the corpus of Christ with the words as well, I thirst. I thirst, and I thirst for you to be near to me, Jesus on the cross, near to me in my pain and in my suffering, and you will be close to me. So the church and other faith-based communities has been at the forefront of providing a person-centered response, and these are some examples. Yet in the Catholic world, we're often told, hold on, you all are the cause of HIV, or John Paul II caused HIV because he would not endorse condom use. And Pope Benedict was very clear that the condom solution for HIV is wrong. This is not going to work. And people said, that you're the enemy. And yet the largest provider of HIV care in the world are Catholic institutions by far, by far. So why is there hostility and opposition as well? Because the Catholics' teaching on human sexuality is so countercultural, and you have to expect it. We're going to bring up HIV and AIDS. You can bring up the knowledge and all this. You should expect a lot of opposition because the church's teachings are so countercultural. And so it's going to happen and should not be surprised. Should not be surprised. So to sum it up a little bit, prevention, testing, and treatment are all linked, can be successful, huge amount of progress in the HIV and AIDS world, and it provides hope. We really can provide phenomenal hope for people with HIV. Abstinence or delay in sexual debut, fewer partners, the be faithful, strategies to decrease concurrency are critical. And the combination, abstinence, be faithful, C for condom use with risky sex, does work and does decrease HIV prevalence rates. Testing is key, has to be routine, and has to be widely implemented. The dignity of the person has got to be the most important aspect of care and prevention. And this includes respect for the family and the culture of the community, which is the only way for it to work well. And a person-centered response in the midst of this terrible, terrible epidemic is desperately needed. So thanks for listening. Thanks also for all caregivers, individuals living with HIV and AIDS, family members who have given so much to themselves and responded to this terrible epidemic and the terrible suffering it's caused. Thanks. Yes, well, unless a couple of people are hidden there, but...
All right, well, if you have some questions, we've got about 20 minutes.
Perfect, great. Yes?
You mentioned a pre-exposure Truvada or Truvada?
Truvada is pre-exposure prophylaxis.
What are your thoughts on that? Is that like, I mean...
You know, let me backtrack and talk a little bit about Pope Benedict's teachings related to condoms. He came out, you know, Pope Benedict is a teacher, and so he's very clear, and he's been very deliberate in what he says. Is again, I'm speaking now as a physician, not as some church authority, and I may be wrong. So that's my disclaimer. So now I can, you know, so now I'll say. But you know, basically, on his trip to Senegal, he said the condom solution is wrong. The condom solution is not going to be the answer to this epidemic. This epidemic is about the human person, those individuals that are vulnerable. What is the human person is created to love and be loved. And that's supposed to be done in a committed relationship, and our sexuality is for a committed relationship with a man and a woman, and understanding this and living this out within a lifelong commitment is the answer to this epidemic. Then, subsequently, he said, this was in an interview with an Italian journalist, he said, you know, if a man involved in sex work, that man using a condom can be a first step in responsibility. And I interpreted that as saying, it's really about the person. It's not all about the condom. What we care about is the person, not about a condom. And yes, for that person using a condom is better than not wearing a condom. Just like if I were to rob a bank, it's better if I rob a bank with a knife than I rob a bank with an Uzi submachine gun, right? On the other hand, the church should not be in a position of saying, oh, by the way, if you rob a bank, let me tell you exactly what type of weapon you should use. The church just says, don't rob a bank. Likewise, the church shouldn't be in the position of saying, if you're going to a brothel, please use a condom, please use 2 condoms, please do this. They say, hold on, if you're going to a brothel, this is not good for you as a person. You're not going to flourish. This is not what you were made and created for. So I think the church is dead on not to get involved in this. But what he was saying was, it's not about a piece of latex, it's about the person. And their human sexuality is a core part of their human personhood, and this is what their human sexuality is all about. So, now, what does that have to do with pre-exposure prophylaxis or Truvada? A man comes in to see me in the office, having multiple sexual partners. It's my, I let him know, gosh, this is a real problem. You're at huge risk of getting HIV. And by the way, what else is going on in your life? Do you have any support? Who are you living with? Do you have friends? And often this alienation, isolation is very extreme, etc. But clearly you should get an HIV test. If you're going to put yourself at risk for HIV, you should use a condom. And if you take Truvada, this pill, beforehand, you will decrease the risk of HIV. Our hope is that person, at least they care enough about their own health to come see me. That's a good thing. And my hope is that they'll, over time, not only try and decrease their risk of HIV, but decrease their multiple partnerships and sexuality, which is in this case very damaging, and say, whoa, this is really harming me as a person. And this is separate. One of the reasons I'm very glad to be here, and for many different reasons. One is because I think the Holy Spirit is here, and it's very, very beautiful, and it's very important for my own faith. But it's also because in my own work over the last 25 years, the number of people I've taken care of with HIV, so many of them are really heroic, incredibly heroic, and many of them are living chaste lives. And they're living chaste lives in isolation and with no support. And it is really quite remarkable. And so Truvada for pre-exposure prophylaxis, if we say, hey, great, everybody can use Truvada all the time, and you can have as much sex as you want, and it's no problem, it's going to be a disaster. And if it's touted that way, it'll be a disaster. There are occasions where it can be, it will be a help as people hopefully, change. Which is what we do always with medicine. We take, somebody's smoking away, we take care of them and help them out and encourage them to stop smoking. Yes?
Actually, wait till I get to you. Who got a microphone down so we can get it on DVD?
Hi, on the question of circumcision, there
Yes.
seems to be a movement now against circumcising babies. I mean, it made the bill all the way in California to be voted on. Was kind of banned in Germany, and I know a lot of young girls who have male babies now are not having them circumcised because they're very big into the organic and natural and that. And in the beginning of the presentation, they were saying that being circumcised reduces the rate of acquiring the virus.
You're absolutely right, and this is an amazing issue. What happened is in this country, during the Second World War, the military circumcised men, actually. And all these guys came back, everybody was circumcised, and everybody said, okay, well, we'll circumcise all our babies. And that was the standard. And there's a pretty rare condition of cancer, penile cancer, which is decreased with circumcision. And it just became largely the norm, not 100% largely the norm. Then in the 70s, 80s, and 90s, people said, well, why are we doing this barbaric procedure? Why are we causing all this harm? And so then people questioned it, and the people said, hold on, let's rechange our thinking. And now comes this data. And so this is an issue, is a very real issue, and your taxpayer money, mine too, is being used to support programs to encourage strongly encourage male circumcision in different parts of Africa where HIV rates are very, very, very high because of the incredible health benefits of it. And so your observations are right on track.
You know, we go against female circumcision.
I'm sorry, say that again?
I said we have been against female circumcision and had come down heavily on that in third world countries.
Right, and because, yeah, but I think that's largely because the mutilation that occurs with female circumcision. What is the benefit of it? It's very interesting. And this is an adult audience, so anyway, clearly I'm wading into deep waters here. But the bottom line is that with circumcision, the skin becomes keratinized. So normal skin has a layer of dead skin on it. That's keratinized. And keratinized skin is a much stronger barrier to all sorts of different infections than mucosa. So non-keratinized tissue, like would occur with just a mucosal layer. With regular mucosa, there are all sorts of activated white cells and lymphocytes that are susceptible to HIV there. So the keratinization of the skin provides a stronger barrier.
We should get 2 microphones here for next time. Sorry, excuse me.
Dr. Flanagan, I was curious about, in Uganda, isn't there an effort to criminalize same-sex?
Absolutely. Yep.
In the matter of public health, how do you discourage the kind of behaviors that can lead to epidemics without making these people, public enemy number one, and making them especially vulnerable to violence?
Yeah, this is really, really important and really critical to understand and figure out. I mean, I think that the church obviously has the answer, which is, it's been, we're all sinners, and for all of us, hate the sin, love the sinner. That whole approach is the right way to look at it. I mean, Mother Teresa's embrace, and who was it that opened the first HIV hospice in San Francisco and New York, but the Missionaries of Charity. So that is clearly the right answer. And it's been a phenomenal privilege for me to take care of so many individuals with HIV, including so many men that have come back to their faith in the midst of their illness. And I am sure that there are going to be a lot of people in heaven that get a direct pass because of the suffering they've endured. And hopefully they'll put in a good word for me. But now, something else happened, which is that in America, the HIV epidemic first started out in terrible proportions in the gay community, and therefore, and the response there was largely condom promotion for understandable reasons, and that did work to a certain degree early on. Rates of HIV did fall in San Francisco, but they've eventually come back up. But what happened is then that around the world, most of the HIV health workers and activists that came from the US came from our context of working largely within the gay community or among injection drug users. And then they went to cultures which are incredibly culturally conservative. And as opposed to kind of working with those countries and promoting their own response and trying to be sensitive to their own perspective, they developed an effort to say, we've got to change them. And the first thing that happened was they said, how can you all be so stupid not to use condoms? And I've had many people from Africa come up to me really furious. You Americans, I had a woman come up to me and say, I have HIV. I've had one partner in my entire life who's my husband of 12 years. And he was HIV infected. And all your programs want to do is come to preach to me about condom use. We've been married. I've had one partner. So then there was a second effort, which was to say, how come your cultures don't accept homosexuality? So then there's been a battleground going on there. And unfortunately, the money comes from the US, North America, and Europe. And when you have money, you have power. So there's a lot of cultural imperialism going on. You're sure you're right. You've got the money. You got the power. The State Department recently said, we want all our funded agencies to tell us how they're going to address discrimination against homosexuality. So if you're giving out malaria bed nets or working with children and nutrition and clean water in Ghana, now you can also say, and tell us how you're responding to discrimination, particularly against homosexuality, gay or bisexual men, however you want to frame it. Well, in those cultures, it's like, what do people say? Like, what are you trying to force on us? So it's unclear, but in Uganda, Uganda is a huge recipient of U.S. aid, and some of this was thought to have been a backlash against this U.S. approach. And it can be quite harmful, obviously, and a lot of work needs to be done.
Do you see certain similarity between using a condom and circumcision as far as philosophical similarity, as far as not doing much about behavioral change?
Well, first off, the whole issue with circumcision, you always need to respect community. You always need to respect family, community, and culture. So family, community, and culture are key. And circumcision has to be seen within the context of that. So circumcision in India, that's a marker whether you're Hindu versus Muslim. So that's, culture there is huge. And family has to be totally involved. But the reason why the data is important is when a woman or a man says to the doctor, are there health benefits related to circumcision? The answer 5 years ago or 8 years ago was no. We do not know of any health benefits related to circumcision. The answer today is yes, there are health benefits related to circumcision. But it's your decision whether you want to do it or not. Obviously, best is a baby. So that's that situation. Condom use is different because condom use is, as soon as you're talking about condoms, you're talking about human sexuality, you're talking about a sexual act. As soon as you're talking about a sexual act, you're talking about the human person and what is best for their flourishing, what is in their greatest good or not in their greatest good. So the condom use is different in the sense that we don't ever want to be in a position of, that's why condom promotion is such a problem. You don't ever want to be in a position of promoting condoms without letting people know that multiple partnerships and human sexuality not within the realm that God created it is harmful. And obviously that's not easy to do, but most important that we do. And the data from Uganda and Kenya just shows that when you do that, people do change their behavior. And we don't do that in this country because we don't want to be moralistic, et cetera, et cetera. But it needs to be done.
Needed to be clear.
Yes.
Could you speak on there seems to be a small portion of the population that seems to be resistant to the HIV? No, there's an article.
Yep. Oh, yeah. Okay.
Can you just repeat the question?
Yep. There seems to be a small portion of individuals that are resistant to HIV. This is absolutely the case. This is a fascinating medical story. There was a man down in New York City by the AIDS and AIDS Institute who went in to see a researcher there, Richard Kaup, and he said, there's something going on. I have multiple partners, a lot of unprotected sex, and I get tested every 6 months, and my test is negative, negative, negative. And I know I'm having relations with people that are positive. Either your test is wrong, or that's a big deal, or I am protected from HIV. So this researcher actually paid attention. Most of the time when someone does that, they say, oh, you must be crazy, see you later. But this researcher said, well, maybe there's something going on here. And he took that person's white cells, drew their blood with permission, took their white cells, stimulated them, revved them up, which makes them susceptible to HIV infection, threw HIV on the white cells, and they couldn't get infected. And that led to the discovery that HIV gets into a human cell by two things. One is a CD4 receptor, which we all have, but another is a molecule called the CCR5 receptor, CCR5. And it turns out that 1 to 2% of people lack both genes for the CCR5, and they have no CCR5 molecules on their cells. They don't have it. If you have one gene, you have the CCR5, but less. So that meant 1 to 2% of people, and it's different based on their racial background, and, but are quite resistant to HIV. Now, we have later found out that HIV can get into those cells through another route, but it's much, much, much harder. So certainly those folks are 100-fold less likely to get infected. So maybe not totally resistant, but quite less likely. And this led to the development of a whole new class of medications that we use to treat HIV, which is amazing. So we've got multiple classes of medications. So that does happen. Again, people then say, well, what are the implications? Well, just because you can get HIV negative doesn't mean you shouldn't live your life the best way you can. But it's biologically was an amazing story and led to better treatments.
I've got a question for you.
Yeah.
My question for you is, this person-centered response sounds absolutely phenomenal. I'm just wondering, is this something that's being done? I'm particularly thinking in terms of the resources. When someone who doesn't even like themselves or care about themselves comes to you, and you sit down with them, is that something that's covered? There's funding to take the person out for coffee and see whether their needs are met?
Yeah, really good question, and there are big implications in terms of funding and policy. So I was with Médecins du Monde in Ukraine, and I stopped at one of their drop-in centers for substance users living on the street, and it literally was a shower, a washing machine, and a coffee pot in this kind of grungy apartment in the basement. And it was there just for that reason. They were doing it. Around the world, most HIV workers, this makes sense, and they're good people, and most of them are doing it. But often our funding is not directed that way. So some of the funding asks, how many HIV tests have you done? How many condoms have you given out? How many clean needles have you given out? Where the metrics which drive the funding are all about this risk-centered response, not the person-centered response. So, and I presented it as a little more of a dichotomy than it is. In the field, people are people, and many, they're really wonderful people involved in this, really wonderful people. And they and they are engaged in this. But we have to make sure that our policies support that. So sometimes they do, it should be more.
Dr. Flanagan, I want to thank you very much for your approach that you so clearly articulate. I've been running a drop-in center for 20 years and work with this approach now, which is really the pastoral approach of the church. In line with this question that you just answered, and I would love a little bit more clarity. We're the church sitting here wondering, how do we implement such a thing? What do I do? I mean, you must admit that the social services are doing the best that they can based on what they know. Risk-centered approach is all they know. We, the church, know more. We know better. Mother Teresa was the great example that you continue to point out. So how do we, the average individual person here at the church, implement what you just talked about? I've realized that we don't have to be professionals. I have a team of volunteers, people, very ordinary people, who do very ordinary things, but they do it with great love. And so much of this approach, which is what you're talking about, is exactly Christ's approach. He leaves the 99 to minister to the one person. And so I just wanted to hear what you would have to say to ordinary people, the church, in terms of what we can do. What kind of apostolates do we, should we be fund-orientated in terms of our motivations, or need we just say yes and go out and start an apostle of mercy somewhere, and the need for that? I see your response with your life is very much that. Going from a practitioner to diaconate to do to a deacon is very much preaching the gospel with your life. I think you're probably feeling that you could be more effective in that regard with Christ's help. And so I just would love to hear what you have to say to us, little people who want to do something but don't know how to.
Well, thank you. And frankly, I couldn't have said it better. I'll make one observation, which is that American culture doesn't know how to deal with suffering. Suffering is seen as an aberration, a mistake. It shouldn't happen. But yet people suffer and suffer terribly with great pain with HIV and in life. And it's a constant for all of us. The one thing we can offer, and it's hard for us as Americans, it's hard for us to learn about the cross and what it really means. But Christ draws us, in our suffering, He is with us and close to us on the cross. So we, particularly in the church, have something very special to offer. Because for people that are totally alone and experiencing great pain, Jesus is saying, I will be specially close to you because of the cross. And you will be specially close to me. And that is beautiful and huge help and solace. And yet, it's counter-America. It's counter our current culture. So all of that about doing what we can do with great love, one-on-one, is at the heart of it. But we also have our I hate to say our understanding of suffering and the cross, because frankly it's a mystery and we don't really understand it. It's too much. But our attempt to try and understand the cross is a huge gift, and a huge gift particularly of the church, because it's not understood, and yet people are in terrible pain and suffering. And we say, you shouldn't be in pain and suffering. If you were to exercise more, and if you took some antidepressants, and maybe if you called somebody and went to Starbucks, got a double espresso, maybe you wouldn't be feeling so bad. And that's right. But they're like, well, I kind of tried that. I'm still in pain. I'm still suffering. The pain is still there. And the cross is a mystery, but it's I don't know how to articulate it well. But as Catholics, we know how important it is for us on a very personal level. And it's so important for us to share that however we can.
Maybe one more question and then we'll break. Thank you. Thank you for your time and for your great talk, Doctor. I have a lot of questions, but I'll limit it to one. Abstinence education was always sort of seen as the pariah, and instead you get a lot of like condoms and pro-gay education. What's the state of abstinence education today?
This is such a political issue within the culture wars, as we all know. The NIH funded a really good study by the Jamaats showing that abstinence education works and that abstinence education is good. And it happened, it was published 3.5 years ago, and it's been totally ignored. So unfortunately, abstinence education is really important. What I think is really interesting is the CDC does a behavioral health survey of American high school students every 5 years. And the last one showed highly statistically significant increases of abstinence among high schoolers. And it was something that the spread was not huge. It was something like 52% to 56 or 57%. It was a 5% increase. The statistics, it was off the charts because this was so many kids. You can't believe it. It also showed, they also asked, among kids that were sexually active, how many had more than one partner in the last 3 months. I may not have the metric exactly right. It's very significant decreases. They also asked, of those who are sexually active, how many used condoms at the time of last sex? That also went up. Why? Because American teenagers don't want to get HIV, and they also want to be healthy and have loving relationships, hopefully for their whole life, and have a healthy family. I mean, these are universal wants. And so therefore, this is happening too locally. We should be doing abstinence education because it works and it's good. But the ABC message, makes sense as well. And unfortunately, it's all become, some of the debate has clouded out what is best for the student.
Thank you,
Thanks.
Dr. Soon-to-be Deacon Flanagan.
Thanks a lot.